Dr. Balavenkat, who will speak for giving lumbar epidurals in anticoagulated patients, and Dr. Sandeep Mutha for not giving lumbar epidurals in anticoagulated patients.
Let me first enter into a peace contract with Sandeep Mutha for having done this conference so very nicely and organized very well. Thank you very much, Sandeep Mutha. If there is one issue that is faced by an anesthesiologist today, which troubles them so much, is two drugs. One is antiplatelets and the other one is anticoagulants, and the relationship with this to the regional anesthesia. With due credence to all the publications, I would say that most of the guidelines which have come in are based on corroborative evidence, and they are mere guidelines. If you analyze all these articles, it is based on perception, and it is based upon people who have done lot of work, who think and have postulated. Otherwise, how do you think we can come to a conclusion that in a patient who is receiving some of these drugs, that the chances of spinal epidural hematoma can be 1 in 1,50,000 or 1 in 2,20,000. If we ask a question to ourselves, how did they arrived? So the guidelines are basically to caution us that there is a chance of increased possibility of a spinal hematoma in few group of individuals. But what is translated and what is its relevance to Indian situation? What is its relevance to hospitals in India? Thanks for Dr. Guru Prasad, who clearly demonstrated what happens in the periphery and what happens in multiple peripheral nursing homes across this country, where the facilities, intraoperative facilities, is itself at a questionable situation. Forget about the post-operative period. So imagine you get a geriatric patient with a hip fracture. I'm not talking about elective procedures. Elective procedures, I think you can strictly adhere to the protocol, that is guidelines that has been given. My concern is more for critically ill patients who come for emergency procedures. Like the typical example is a geriatric patient coming with a hip fracture who is on an anticoagulant or an antiplatelet. What are the two options? One of the option is just wait for 7 days until the antiplatelet activity is over and then try to take him for a neuraxial block. Many people follow this. There's another group which say that you do this case under general anesthesia. So these are the two possible options that are available. This is okay in all the corporate units and units which has got a high dependency unit. But what happens when you work in a hospital which does not have oxygen in the oxygen cylinder or the post-operative care? How do you give a general anesthesia to a neck of femur fracture who has got a COPD, emphysema, Parkinsonism, CVA? So now the question is, considering the infrastructure in which you work, I personally feel you have to make a choice between what would be the most safe thing to give to this patient. And if you think that the infrastructure is bad, and if you give a general anesthesia and produce 1 in 1 mortality, or compare it to giving a regional anesthesia and accept 1 in 2,20,000 possibility of a neurological deficit. I seriously wanted all of you to think about this. One of the best options that would be available is explain the risk to the relatives about the possibility of having a spinal epidural hematoma after your neuraxial block. Get a written consent. Tell them that though that is reported in the literature, but the incidence is very rare, and considering all the infrastructure and considering the abilities there available, you can say that you would still go ahead with a neuraxial block and give a safe post-operative period. With this submission, I would go into the... Now two things are important. One is the anticoagulated patients. Initial thinking was we should have an INR of 1.5 to safely give an epidural catheter. This has recently been sort of challenged, and a few months ago it appeared in Anesthesiology. It was a cover page editorial that now that group has shown that even with an INR of 1.9, they safely placed epidural without having an hematoma. This is regarding anticoagulation, INR and epidural catheters. The next thing is in relationship between the antiplatelets and putting an epidural catheter. This article, written by again the renowned Terceti Herlocker, pre-operative antiplatelet therapy, she says, does not increase the risk of spinal hematoma associated with regional anesthesia. She did a continuous study in about 1,000 orthopedic patients, 1,000 orthopedic procedures in 924 patients who received antiplatelet agents, did an exit scanning imaging and found out that none of them had an epidural hematoma. This article, the safety of spinal anesthesia in patient with recent coronary stents. This is again very, very important. If you stop the antiplatelet drugs and take them for procedure, remember that if this is going to be less than 6 months, then there is a high possibility of the stent getting occluded and producing a catastrophe. So this particular article says that spinal anesthesia, they followed up all the patients with stents with continuing antiplatelets, and then these patients received a spinal anesthesia safely to undergo the procedures. Now, this is a very excellent guideline, a clinical guideline for perioperative management of a patient receiving antiplatelet therapy. I would like all of you to really emphasize on this and discuss this with your surgeons. Now, the consensus is, if the patient is on aspirin, continue the aspirin. Now it has been found 75 milligram daily is a very good dose which can result in a good antiplatelet activity. So continue aspirin 75 milligram on patients who need it without stopping it, and still you can give a neuraxial block. That's point number 1. Point number 2, if these patients are on clopidogrel and they are coming to you, you stop clopidogrel and convert them, put them on an antiplatelet for 7 days if it's an elective procedure, and they take them for surgery. If these patients are on clopidogrel and you cannot stop an antiplatelet agent because they have to undergo an emergency surgical procedure, then you put them on a short-acting antiplatelet like the fluorobioprofen, which is not available. We have got tirofibin, which is to be given at 0.15 ml. I think my cardiologist told me a dose, but we do not practice it. But this can be done, a short antiplatelet drug, which the action can last only for 6 hours, especially when you deal with patients with stents whom you have the antiplatelets to be given. I think later Murli can tell us whether they use it. So in a nutshell, if you think the regional anesthetic technique is extremely useful, one more point I would like to say, many of them stop these antiplatelets for patients on stent and put them on low molecular weight heparin. It has been proved that it is of no use. There is no use in putting the antiplatelet activity and the low molecular weight heparin activity are totally different, and in patients with stents they do not make any sense to stop aspirin and tell them I put them on a low molecular weight heparin and go ahead for the procedure. So it's better to go for the short-acting antiplatelet drugs. In a nutshell, the question is whether you want your patient to survive at the end of the procedure by doing a regional technique if you think it is far more superior to your general anesthesia, considering their comorbid conditions like CVA, Parkinsonism, profound COPD and emphysema, or worry about the possible complication of 1 in 2,20,000, which is empirical, which is postulation, which is a protocol which has not been proved. The answer is going to be decided by you, but the solution should be decided by you with a consensus with your surgeon, and the ultimate aim is you should choose a procedure which is safe, procedure that is convenient and comfortable to the environment that you work, and see that the patient goes back home. Thank you very much.